Diagnosis of late puberty in a bare medical history, standard staging, BMI, serum age, FSH, testosterone, estradiol, if lower, number FH, FSH with low TE. Constitutional group delay isolated GnRH deficiency functional hypogonadotrophic hypogonadism if elevated TNH FSH with low TE primary hypogonadism X-ray to check age of the bone other like TSH IGF-1 prolactin absent or incomplete development of secondary sex characterized by 13-year-old or 14 in a boy tenor staging absent breast buzz pub bone age X-ray is less than individuals chronological age family history of puberty constitutional muscular pathology hypergonadotrophic hypogonadism insufficient sex steroid production low estrogen and pituitary increase in pituitary gonadotropin FSH at age primary gonadal insufficiency Turner syndrome underbalance stability syndrome CardiB for diagnosis, secondary gonadal insufficiency, chemotherapy, pelvic dilation, infection, trauma, severe autoimmune disease, stroke, past, mechanical history, hypogonadotrophic hypogonadism, sinus lesion, common syndrome, idiopathic pedophilia, malnutrition, anorexia, chronic disease, irritable bowel disease, hypothyroidism, cystic fibrosis, test to conduct testosterone at age FSH, estradiol low or normal constitutional growth delay, isolated, GnRH deficiency, functional hypogonadotrophic hypogonadism, hypothalamic pituitary disorder, elevated primary hypogonadism, L-hand with X-ray to compare bone age against chronological age, serum prolactin level, prolactinemia, IGF-1 level exclude growth hormone deficiency TSH and T4 to evaluate amenorrhea and hypothyroidism karyotype for Turner syndrome, CBC for systemic disorder, abdominal ultrasound for orgasm, Turner syndrome, head MRI for suspected prolactinemia, diagnosis in a 6-year-old child with malnutrition. Stunted growth, low birth weight, but may also be variable in Cuba, show bradycardia, hypotension, pancreatic insufficiency, hypothermia, primary protein energy malnutrition (PEM) can develop in severe cases. Clinical diagnosis: Cuba core muscle atrophy, pitting edema, distended abdomen, enlarged fatty liver, thin, dry, peeling skin with areas of hyperpigmentation, hair loss, round cheek, moon face, variable weight, apathic effect, sufficient calorie intake, but deficiency of dietary protein, premature cessation of breastfeeding, chronic GI infection, and protein diet, marasmus, more common diffuse loss of muscle and fat, essential Crohn's extremities without edema or distended abdomen. Frontal chest bone ribs, facial bones, dry dry, thin dry skin, thin sparse hair, total calorie deficiency of our macronutrients, irritable effect diagnosed through clinical diet features and low range for length, height, and with upper arm circumference. Laboratory testing should also be conducted to evaluate severity and complications. Secondary PM from illnesses affecting appetite, digestion, absorption, metabolism, or increased unmeasured protein demand. Clinical diagnosis: muscle atrophy. They also have picture of marasmus, short core, seen in neoplasm. AIDS, chronic renal failure, congestive heart failure, COPD, cystic fibrosis, Crohn's disease, chronic liver disease, pancreatic insufficiency, chronic infection, hyperparathyroidism, dilated subcutaneous fat, and skeletal muscle as in marasmus, lower extremity edema, bradycardia, hypotension, hypothermia, delayed wound healing, easy infection, considered possible childhood treatment, neglect other tests, CBC, anemia, electrolyte abnormalities, hypokalemia, natremia, postpartemia, calcemia, magnesemia, low serum albumin and transferrin, especially kwashiorkor, low blood glucose, increased CRP, associated with inflammatory condition tests for over and parasites in stool culture, delayed puberty. Inverse defined as essence of breast development by the age of 13, the essence of menarche by the age of 16, regardless of the onset of breast development. The cause can be constitutional or family tendency towards the later development, hormonal imbalances, chronic illnesses, or structural abnormalities. Here's an outline for diagnosing delayed puberty in girls, characteristic symptoms and physiology symptoms: lack of breast flap development by age 13, absence of menarche by age 16, or more than 5 years between initial breast growth and menarche. Pathophysiology can involve the hypothalamic pituitary gonadal axis disruption leading to insufficient secretion of gonadotropin, NH at best stage, and subsequent to its proven clinical presentation and diagnosis, medical and family history, detailed history to identify anything familiar patterns to of delayed puberty, nutritional problem, chronic disease, or symptoms suggestive of systemic illnesses. Physical examination assess growth pattern, body proportion, and tenor staging to evaluate pubertal developmental stage. Bone age assessment, X-ray of the left hand and wrist to assess bone age, which can help differentiate between constitutional delay and other causes. Laboratory tests, gonadotropin and HNL stage, baseline level, and are responsive to GnRH, gonadotropin-releasing hormone stimulation test. Thyroid function test throughout hypothyroidism, prolactin elevated level can indicate a pituitary disorder cardiac analysis. Now, particularly if Turner syndrome is suspected, 45X0, IGF-1 and IGFP3 to assess growth hormone status. Imaging MRI of the brain may be indicated if a central cause of delayed puberty, hypothalamic, or pituitary tumor is suspected. Treatment depends on the cause, may range from observation for those with constitutional delayed hormonal replacement therapy for those with hormonal deficiency. Estrogen therapy, low dose estrogen can be initiated to induce secondary sexual development with gradual increases to mimic normal puberty progression. Vary etiology generally prevalent in constitutional delay in managed appropriately. In case due to chronic systemic disease or genetic condition, the prognosis depends on underlying causes. Differential diagnosis, constitutional delay of growth and puberty, CTGP, family history of delayed puberty delay but normal growth pattern over response to GnRH stimulation test. Hypogonadotropic hypogonadism, lower HFSH level, absence of pituitary hormone deficiency, low or normal gonadotropin with poor responses to GnRH stimulation, hypergonadotropic hypogonadism, Turner syndrome, strict gonads, shield chest, show stature, elevated gonadotropin, normal karyotype, chronic systemic disease history of chronic illness, poor growth, velocity, disease specific finding, low IGF-1, hypothyroidism, fatigue, cold intolerance, constipation, elevated TSH, low TF. T4, delayed puberty in girls is diagnosed when there is an absence of breast development by 13 years or your manner by 16. Evaluation works, thorough history and physical examination assessment of growth and development, bone age of determination, and targeted laboratory tests to identify the underlying cause. Treatment is cause-specific with hormone therapy to induce puberty in some cases. Identifying the cause of delayed puberty is then support appropriate management and to guide expectation for development and applying other take. So let's know diagnosis of delayed puberty in environment, medical history, tenor staging, BMI, serum, LH, FSH, testosterone, estradiol in below or normal, LH, FSH with low TE, of institutional growth delay, isolated GnRH deficiency, functional hypogonadotrophic hypogonadism, elevated LH, FSH with low TE, primary hypogonadism, X-ray to check the age for both, like TSH, IGF-1, prolactin absent or incomplete development of secondary sex characteristics by 13-year-old, tenor staging absent, breast problem with auxiliary hair menarche, physiological constitutional growth delay, bone age, X-ray is less than individual chronological age, family history of puberty, pathology, hypergonadotropic hypogonadism, insufficient sexual steroid production lowers proven history, increase in pituitary gonadotropin FSH, LH, primary gonadal insufficiency, Turner syndrome, androgen insensitivity, Turner syndrome karyotype for diagnosis. Secondary gonadal insufficiency, chemotherapy, pelvic irradiation, infection, trauma, surgery, autoimmune disease, truth, past medical history, hypogonadotropic hypogonadism, CNS lesion, Karman syndrome, idiopathic breast relay, malnutrition, anorexia, chronic disease, IBD, hypothyroidism, cystic fibrosis, test conduct, serum age, FSH, estradiol, or normal constitutional growth delay, isolated GnRH deficiency, functional hypogonadotropic hypogonadism, hypothalamic pituitary disorder, elevated primary hypogonadism, LA, and wrist X-ray to compare bone age and chronological age, serum prolactin level, IGF, prolactin on the IGF-1 level, exclude growth hormone deficiency, TSH, and T4 to evaluate amenorrhea and hypothyroidism, karyotype or for Turner syndrome, specific for systemic disorder, abdominal ultrasound, ovarian, Turner syndrome, MRI, suspected prolactin on the diagnosis in 60-year with malnutrition. Okay, stunted growth, low body weight, bradycardia, hypertension, pancreatic insufficient heart starting terminal inflammatory protein and human fusion clinical push core Lord O'Kane 정신을 하면서 급속도로 오지 다시로기 and autopy college of cutaneous bed and skeletal Alternative or characteristic symptoms and pathophysiologic symptoms, pathophysiology, medical and family history, physical examination for aging assessment, laboratory test, gonadotropin, NH and FSH, thyroid function test, routine cardio, karyotype analysis, IGF-1, IGF-1, P3, causes growth, growth hormone status, imaging, MRI. Depend on the cause, best for therapy. Performance vary on the etiology and delay puberty courses diagnosed 20 sections of breast development and 13-year-old male menarche by 16 evaluation was a thorough history and physical examination assessment of growth and development when age determination and targeted laboratory tests to identify underlying cause treatment is non-cause specific. Need hormone therapy to induce puberty in some cases.